This is a video presentation of the Mrs. Berry case study. To practice the skills described in Learning Outcome 4 within the limitations associated with the theory-based learning of a very practical set of skills, I've completed the case study provided within the learning materials of the Applied Nutrition Support module. I've chosen to complete the case study for the first 3 days of the patient's hospital admission prior to the introduction of enteral feeding, as I felt this was beyond the scope of this learning contract. Having done external reading and made notes which I've uploaded onto my e-portfolio, I followed the model and process for nutrition and dietetic practice from identification through to intervention planning. In this video, I'll run through the case study, my decisions and the planned intervention. I'll also discuss some of the additional questions that I would ask the patient in a real-life situation. Identification of nutritional need. Having used the MUST tool, I identified that the patient has a MUST score of 4, which places her at high risk of malnutrition. This is based on her BMI being below 18.5 kilograms per metre squared, which gives a score of 2, and a recent weight loss of approximately 20%, which gives a score of 2 as well. A MUST score of 2 often indicates a dietetic requirement involvement, and so this brings me to the assessment stage. Assessment. As per Learning Outcome 4, to assess the patient and their needs, I need to identify and collect important patient information. I'm also attempting to interpret this information to allow me to fully understand the patient's nutritional status and needs. In this case study situation, as would likely be the case in real life, I began the assessment by looking through the medical notes. Firstly, I gathered basic patient information and made a note of these details on the dietetic referral document, for example, the patient's name, date of birth, past medical history and social information. To identify appropriate patient data, I followed the ABCDE approach when going through the medical notes. I'll go through each section of this system now. So A for anthropometry. I used the recorded weight and height information to calculate the patient's BMI as being 18 kilograms per metre squared. I also noted the patient's last known weight of 55 kilos, which would suggest significant weight loss of around 20%. Obviously, I was not able to visually assess the patient. However, I have noted that according to the medical notes, she appears very thin and is feeling lethargic. This would indicate potential inadequacy in nutritional intake. So B, biochemistry. I've looked at the patient's blood test results on day 1 and again on day 3 when I have theoretically visited the patient. I've noticed that her albumin level is low and decreases from day 1 to day 3. Predominantly, a low albumin is thought to indicate inflammation and infection, and although albumin levels can be influenced by nutritional intake, its use is not recommended to determine nutritional status. White cell count and C-reactive protein are also above the ranges stated in PENG. White cell count is an immune system marker, so indicates that infection may be present, and C-reactive protein is an inflammatory marker, which again indicates infection or inflammation. Based on the biochemistry alone, there is suggestion of some form of inflammation and infection, and it's important to be aware of this when assessing them, as it will likely impact on their nutritional status. So C for clinical. I've made a note of the patient's previous and current medical condition and diagnosis of a fractured right femur. The patient's history of osteoporosis is relevant given the fracture diagnosis. However, in the short term, management of this condition is not likely to be a dietetic priority. The priority will be preventing further deterioration. It's also relevant to note down the patient's Oromorph prescription due to the potential side effects of this. For example, nausea, dizziness and vomiting, which may be influencing the patient's desire and ability to eat. As mentioned, the theoretical nature means I'm unable to visually assess the patient. However, she is noticed as appearing thin, which is important. D for dietary. As per the ABCDE assessment, we need to establish the extent to which the patient's nutritional needs are being met, as this is central to the dietetic nutritional assessment. To do this, I've calculated the patient's estimated energy and protein requirements using the 5th edition PENG calculations as follows. The patient's BMI is out of normal range, so rather than using the disease or condition-specific calories per kilogram, I'm going to refer to the standard 25 to 30 calories per kilogram, which would equate to 1,100 to 1,320 calories. As the new PENG calorie figures incorporate the condition stress factor, I only need to add the activity level or diet-induced thermogenesis factor. As the patient is bed or wheelchair bound but mobile within these confines, I've estimated an activity factor of 1.1. This brings her estimated caloric requirement to 1,210 to 1,452 calories. As per the PENG guide for older adults, those aged 65 and over, with complicating medical conditions, I've estimated the patient's protein intake to be 1.2 to 1.5 grams per kilo, which equates to a protein requirement of 53 to 66 grams of protein per day. I've then used the 3 days of food record charts provided to estimate the patient's intake. Based on my estimations, the patient is consuming between 492 and 956 calories and 12 to 33 grams of protein per day, with intake decreasing since the start of admission. Based on this, the patient is likely to be in an energy and protein deficit of approximately 400 to 800 calories and 26 to 50 grams of protein. These estimations indicate inadequacy in intake, which needs to be explored further. This leads me on to exploring the patient's decrease in appetite and weight to identify any potential causes or influential factors. So E for environmental, social and psychological. When looking for a potential cause of nutritional issues, it's important to consider factors beyond medical issues, as there are numerous social and psychological issues which may influence a person's nutritional status. From the initial collection of information, I can see that there have been significant changes in Mrs. Berry's personal life recently, for example, her husband passing away. Of course, a connection between this and Mrs. Berry's nutritional intake should not be assumed, however, it would be logical and important to explore this further with the patient. In addition, the patient now lives alone in a secluded area. Further details would be required to gain a full picture of Mrs. Berry's home environment. However, the suggestion of her being secluded indicates potential issues in access to food and social support. Before exploring social issues at home, it would also be important to address the hospital environment, as this may be impacting on the patient's appetite and oral intake. Whilst completing the assessment, in addition to the assessments and conclusions drawn using the information from the patient's medical notes alone, I compiled a list of questions I would like to ask the patient to gain a clearer picture, and I've uploaded these onto my e-portfolio. However, I continued the theoretical assessment without having this additional information as follows. So the diagnosis. The diagnosis stage of the dietetic process is the identification of nutritional problems which may impact on the individual's physical, mental or social well-being, where the dietitian is responsible for action. In this case, the diagnosis reflects an existing nutritional problem which can be evidenced. To document the diagnosis, I've used the PASS system, which describes the problem, etiology, signs and symptoms. So the problem is significant weight loss, declining intake during initial admission, and oral intake not meeting energy and protein requirements. The etiology is a fractured right femur and related treatment. There is also potential for some psychological factors to be exacerbating the issues. The signs and symptoms are that the patient appears thin, weight loss has been recorded, the patient feels lethargic and reports reduced appetite. There are also food record charts showing limited intake and declining intake. Planning of the intervention. Based on the diagnosis and conclusions discussed, I have planned an initial intervention which sets out the activities and resources used to address the identified nutrition and dietetic diagnosis. This should always be patient-centred, with the planned steps being guided by the patient. For this case, I have identified the need to prevent further weight loss and loss of lean tissue to prevent further decline and support recovery as the overall intervention aim, as this is specific and measurable and, if achieved, should improve the patient's signs and symptoms of diagnosis of malnutrition. To achieve this goal, the objectives are as follows. Ensure the patient is offered snacks regularly throughout the day, i.e. between all meals. Ensure the patient orders meals off the high energy and protein menu. Explore alternate flavours and brands of the oral nutrition support supplements to see if any would be acceptable for the patient. Obviously, these objectives have been determined without the patient's input, and in reality I would have discussed these in more detail with the patient to ensure they were realistic and achievable for them. So monitoring. To monitor the patient, I would request daily weights initially, as it would be important not to wait too long between weight checks, as further decline would be increasingly detrimental to the patient's health. I would request continued daily food and fluid record charts to monitor intake and assess how effectively the planned interventions are being administered. I would also want to continue monitoring the patient's biochemistry to detect any changes in infection or nutritional status. So, follow-up. My follow-up plans would be to review the patient in 3 days. This allows some time for the interventions to be put into place and for the patient to get used to the changes. However, it is soon enough that if there are any issues, for example, the patient is unable to incorporate snacks into her day, then this can be addressed and a new course of action decided upon before the patient's nutritional status worsens. In the long term, I would consider referring the patient for an outpatient dietetic appointment to support her ongoing health once discharged. So that's the end of the case study. Thank you for listening.